Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the pulmonology, that is the pulmonary function test. So first of all, you need to know what is the purpose of measuring this pulmonary function test. The purpose of measuring this pulmonary function test is mainly to differentiate the obstructive lung diseases from the restrictive lung diseases. Right, to differentiate obstructive lung diseases from restrictive lung diseases. So that is the main purpose of this pulmonary function test. And how will you differentiate obstructive from restrictive lung diseases via pulmonary function test? So within the pulmonary function test, we measure the various parameters like tidal volume, inspiratory reserve volume, expiratory reserve volume, and then residual volume. Then followed by that, we also measure the capacities, inspiratory and functional residual capacities, vital capacities, and total lung capacities. So by measuring these various parameters, we will be able to differentiate the obstructive lung diseases from the restrictive lung diseases. And you need to know what is the instrument with which you measure the pulmonary function test. So pulmonary function tests are measured with spirometer. Okay, spirometer is the device which measures the pulmonary function test. Now, with the help of spirometer, there are certain pulmonary functions which cannot be measured. That is a very important multiple choice question. Spirometer or spirometry cannot measure the residual volume. Right, cannot measure the residual volume. Okay, what is the residual volume and all we will discuss in detail subsequently. And this spirometer can also not measure the total lung capacity. Right, total lung capacity cannot be measured by your pulmonary function test, that is the spirometer. And the residual volume and the other important pulmonary function test which is not measured by your spirometry is the functional residual capacity. So these are the volumes and capacities that cannot be measured by your spirometer, right? This is a very important multiple choice question. Now, if you observe here the instruments, see, this is the spirometer, right? So what the individual has to do? The individual has to do a deep inhalation and then a forceful exhalation into the device which he has placed into the mouth, by which you can measure the various volumes and as well as capacities. So we have discussed that spirometer cannot measure the residual volume, total lung capacity, and then functional residual capacity. Then how is this residual volume measured then? Right, how is this residual volume measured then? See, residual volume is measured by body plethysmography and residual volume can also be measured by helium dilution method and residual volume is also measured by nitrogen washout method. So these are the various methods by which the residual volume is being measured. Now the instrument which is being shown to you here is body plethysmography. Right, it is body plethysmography. Okay, so this is the instrument with which we measure the residual volume, and these are the various methods. And the best method of measuring the residual volume is by body plethysmography. Now, these ventilatory functions, it can be assessed in two ways. Now, what are the two ways by which the ventilatory functions can be assessed? Number one, under static conditions, and number two, under dynamic conditions. Now, what are those under the static conditions? Static conditions, the volumes and capacities that we measure is mainly total lung capacity we measure under the static condition, vital capacity we measure under static condition, and then inspiratory capacity we measure under the static condition. What are these various volumes and capacities? We will discuss in detail subsequently. Whereas under dynamic conditions, the volumes or capacities which are being measured is forced expiratory volume, right? Forced expiratory volume, and another important parameter which is being measured is forced vital capacity, right? Forced vital capacity. So these are the volumes and capacities which are measured under the dynamic conditions. Now, if you see the purpose of the pulmonary function test, already we have discussed. That is, right? That is to differentiate between obstructive lung disease from the restrictive lung disease, right? That is the purpose of measuring the pulmonary function test. Now, next important point you should remember that the volumes can be assessed in two ways. One is your static and as well as the dynamic conditions. But please remember, the one, that is the pulmonary functions which are measured under dynamic conditions are more helpful, right? The pulmonary functions which are measured under dynamic conditions they are more helpful. Okay, that is a purpose of your pulmonary function test. Now, out of all the various parameters, which is most useful? This is an important multiple choice question. So, forced expiratory maneuvers, right? Forced expiratory maneuvers. These are the most useful in distinguishing these two disorders, that is obstructive lung diseases from the restrictive lung diseases. Okay. Now, before going ahead with the discussion in detail of OLD and as well as RLD, first let me discuss the basic physiology of various volumes and capacities, and then later on let me apply those volumes and capacities to differentiate the OLD from the RLD. So, the first one is the total lung capacity. So, how do you define the total lung capacity? It is the volume of air in the lung at maximal inhalation is what is called as the total lung capacity. Okay. So, it is a volume of air in the lungs after maximum inhalation, right? That is what is called as the total lung capacity. So, now you see here, this is your total lung capacity. What are all included in total lung capacity now? Inspiratory reserve volume, tidal volume, expiratory reserve volume and residual volume. All these volumes are included in the total lung capacity. Now, how much is the normal total lung capacity? It is around 6 liters. Then, what do you understand by this term? Tidal volume. See, tidal volume, it is a volume of air which is moved into and out of the lungs, right? It is a volume of air which is moved into and out of the lungs. Okay, so that is what is your tidal volume. And how much is the normal tidal volume? The normal tidal volume is around 0.5 liters, right? That is around 500 ml. Then coming to the expiratory reserve volume. So if you see this expiratory reserve volume, this will be your expiratory reserve volume. Okay. So how is it defined? Expiratory reserve volume, it is the maximum volume of air that can be exhaled from the end expiratory position. You see, this is the normal inspiration and this will be your expiration. So from end expiratory position, whatever the volume of air that is exhaled maximally, that will be your expiratory reserve volume. Okay, so it is maximum volume of air exhaled from end expiratory position, right, is what is called as expiratory reserve volume. And how much is the expiratory reserve volume? Normally it is around 1 liter, right? So normal expiratory reserve volume is around 1 liter. Then coming to the other important parameter, that is residual volume. Okay, so this will be your residual volume. So how do you define residual volume? So residual volume, it is the volume of air remaining in the lungs after maximum exhalation. Okay, it is the volume of air in the lungs after maximal after maximum exhalation. That is what is called as the residual volume. And how much is the normal residual volume? This will be a very important multiple choice question. That is around 1.2 liters. That is the maximum volume of air that is remaining within the lung after the maximal exhalation. That is around 1.2 liters, which is nothing but residual volume. Then coming to another important terminology, that is inspiratory reserve volume. How do you define this? See, inspiratory reserve volume, it is the maximum volume of air that can be inhaled. You see here, this is the inspiration and this is the expiration. And this is the inspiration. So, from end inspiratory position, right, from end inspiratory position, the volume of air that is inhaled maximally, right, from end inspiratory position, the volume of air that can be inhaled maximally, that is what is called as the inspiratory reserve volume. Okay, so it is the maximum volume of air that is inhaled from end inspiratory position. That is what is called as the inspiratory reserve volume. So this entire thing will be your inspiratory reserve volume. And how much is the normal inspiratory reserve volume is also a very important multiple choice question. So the normal inspiratory reserve volume, it is around 3.3 liters. That is the IRV. Then coming to the inspiratory capacity. See, capacities are nothing but it is the summation of the volumes. So when you sum up the inspiratory reserve volume and tidal volume together, what we get is the inspiratory capacity. Right? What we get is the inspiratory capacity. So inspiratory capacity is inspiratory reserve volume plus tidal volume. Okay, so this is what is called as the inspiratory capacity. Then coming to the vital capacity. So how do you define this vital capacity? It is very simple. Total lung capacity minus, right, this is the total lung capacity. Total lung capacity minus residual volume. That will be your vital capacity. Right, total lung capacity minus residual volume will be equivalent to that of your vital capacity. Then finally, coming to the functional residual capacity. What is functional residual capacity? You see here, this is the functional residual capacity. See, it is residual where in the lung. It is the volume of air in the lung, right? It is the volume of air in the lungs at end expiratory position. Right, at end expiratory position. Okay, so that is what is your functional residual capacity. So what are included in the functional residual capacity? Functional residual capacity, it includes residual volume, right, and as well as the expiratory reserve volume, right, as well as the expiratory reserve volume. So that will be your functional residual capacity, right. Now, having discussed about the volumes and capacities, now let me discuss the dynamic lung functions. And particularly you have to know that in dynamic lung functions, we also take time factor into consideration. So, FEV₁, that is forced expiratory volume at the end of the first second. Okay, so FEV₁, it is defined as the volume of air, right? It is the volume of air exhaled at the end of, right, at the end of the first second of forced expiration, right? It is the volume of air exhaled at the end of first second of forced expiration. That is what is called as FEV₁. And you take FVC, that is forced vital capacity. Forced vital capacity, it is the determination of vital capacity. You see here, this is the vital capacity, right? It is the determination of it is the determination of the vital capacity from a maximally forced expiratory effort. Right, from a maximally forced expiratory effort. Okay, so that is what is your, right, that is what is your FVC, that is forced vital capacity. It is the determination of the vital capacity from a maximally forced expiratory effort is what is called as the FVC. Right. Having discussed about the FVC, we have another important terminology called as the diffusion capacity. So, for assessment of diffusion capacity, we use the carbon monoxide. Right, we use the carbon monoxide. So, we call this as DLCO. Right, that is diffusion capacity of the lung for carbon monoxide. That is what is called as DLCO. Now, diffusion capacity, it is the part of the comprehensive series of the tests. And what is the purpose of measuring this diffusion capacity? It is done to determine the overall ability of the lung, right? It is done to determine the ability of the lung, right? Ability of the lung to transport the gas into the blood and out of the blood, right? Into and out of the blood. Okay, so that is what is called as the diffusion capacity, right? And for that we use carbon monoxide in order to assess how is the diffusion capacity within the individual. Next, followed by that, we have another important parameter called as FEV₁ by FVC. Now, what is this FEV₁ by FVC? See, it is a percentage of vital capacity, right? It is a percentage of vital capacity which is expired, right? Which is expired in the first second in the first second of maximum expiration. Right? It is the percentage of vital capacity which is expired in the first second of maximum expiration is what is called as FEV₁ by FVC. And how much is the normal FEV₁ by FVC? Normal value is around 70%. Whereas in patients with the obstructive lung diseases, the FEV₁ by FVC is reduced and it can be as low as, right, it can be as low as 20 to 30%. Now, in case of obstructive lung diseases, why your FEV₁ by FVC is reduced, we will discuss. So, what is FEV₁ by FVC? It is the determination of your vital capacity. which is expired in the first second of maximum expiration. Then you see in patients with restrictive lung diseases, in restrictive lung diseases, the FEV1 by FVC, either it is normal or increased, right? Either it is normal or increased. That is what is your FEV1 by FVC in restrictive lung diseases. Then another important parameter that you need to know is your peak expiratory flow rate. So this peak expiratory flow rate is the one which measures, right, is the one which measures how quickly one can exhale. Okay, that is what is your peak expiratory flow rate, right? This measures how quickly one can exhale, is called as peak expiratory flow rate. And this peak expiratory flow rate, it is decreased in, right, it is decreased in the obstructive lung diseases. And this peak expiratory flow rate, it is measured with the help of the peak flow meter. Right, it is measured with the help of peak flow meter. Okay, so this peak expiratory flow rate, it is reduced in obstructive lung diseases. Okay, now this peak flow meter, it is used as bedside assessment of, right, it is used as bedside assessment of pulmonary functions. Right, bedside assessment of the pulmonary functions. Okay, so that is what is the peak flow meter. Now, after having discussed about the peak expiratory flow rate, we have one more parameter that we need to discuss, that is forced mid expiratory flow rate, that is 25 to 75%. Now, if you see the forced mid expiratory flow rate, how is this defined? This forced mid expiratory flow rate, it is the average rate of airflow during mid portion of the FVC, right? It is the average rate of airflow right? Average rate of airflow during mid portion of the FVC. That is what is called as the forced mid expiratory flow rate. Okay, and what is it useful for? This is mainly done to assess for smaller airway diseases. Right? So this is more specific for smaller airway diseases. Now, what are the examples of smaller airway diseases like COPD, bronchial asthma, hypersensitivity pneumonitis? These are all the smaller airway diseases. Okay. Now, this forced mid expiratory flow rate, it is reduced in both obstructive lung diseases and restrictive lung diseases. Right? It is reduced in both obstructive lung diseases and restrictive lung diseases. But it is very sensitive right? It is very sensitive for obstructive lung diseases. That is about your forced mid expiratory flow rate. So, forced mid expiratory flow rate, this is the average rate of airflow during mid portion of the FVC. It is reduced in both OLD and RLD. It is very sensitive for obstructive lung diseases and it is more specific for the smaller airway diseases. Okay. Now, so these are the various volumes and capacities which we need to know or which we need to understand before going ahead with the discussion of the obstructive and as well as the restrictive lung diseases. Now, let me tell you what is the systematic way to interpret the pulmonary function test, right? So, step one is that you have to look at FVC, right? So what does this FVC stands for? FVC, it stands for forced vital capacity, right? And already I have discussed about your FVC. So FVC, it is the determination of the vital capacity from a maximally forced expiratory effort. That is what is called forced vital capacity. And you have to check whether it is within the normal limit or not, right? Yes or no. Then the second step is to determine the FEV₁, right? Look at FEV₁. So what does this FEV₁ stands for? The FEV₁, it stands for, it is the determination of the expiration at the end of the first second, right? It is the determination of the volume of air that is exhaled at the end of forceful expiration is what is called FEV₁. And check whether this is within the normal limits or not, right? And step 3 is that if both are normal, right, if you are both FVC and FEV₁, if both are normal, then you need to consider it as the presence of normal pulmonary function tests. Okay, then you take step 4. Step 4 is that if FVC and FEV₁, if both of them are reduced, right, if both of them are reduced, then the presence of disease is highly likely. And what is step 5? If the step 4 indicates that there is disease, right, if the step 4 indicates that there is disease, you need to measure FEV₁ by FVC value, right? You need to measure your FEV₁ by FVC value, which is nothing but FEV₁ percentage, right, which is nothing but FEV₁ percentage. So this is about the systematic way to interpret the pulmonary function test. So having discussed about how to interpret the pulmonary function test, now let me come on to the obstructive lung diseases. So first of all, you should know what is the definition of the obstructive lung diseases. See, obstructive lung diseases, they are a category of respiratory diseases which are characterized by airway obstruction, right, which is characterized by the airway obstruction. So the individual has an obstruction, and this obstruction is mainly during expiration, and it is not during the inspiration. The inspiratory component is fine within the individual, but mainly during expiration, the individual is having an obstruction within the airways. And if you observe the airways in these individuals, airways in these patients with the obstructive lung diseases, they are inflamed and they are easily collapsible. Right, they are inflamed and easily collapsible airways. Right, and there is an obstruction to the airflow, and the problem is mainly during the expiration. Right, the problem is mainly during the expiration. And what is the hallmark of in obstructive lung diseases? The hallmark of obstructive lung disease is that there is decrease in the expiratory flow rates. right? There is decrease in the expiratory flow rates. That is the hallmark of the obstructive lung diseases. Why? Because the problem is mainly during the expiration. So that is the reason why the hallmark of the OLD is decrease in the expiratory flow rates. Now, what are the examples of the obstructive lung diseases? So please remember this mnemonic ABC, or A, B square, C square. Okay. So A stands for asthma. B, it is your bronchiectasis. Right? B is your bronchiectasis. And another B is your bronchitis or bronchiolitis. C is your COPD, that is chronic obstructive pulmonary disease. And another C is your cystic fibrosis. Okay, so this is what is your A, B, C stands for the obstructive lung diseases. Now, after having discussed about the basic definition of the obstructive lung diseases, let me tell you what will be the pulmonary function in the obstructive lung diseases. And before that, you see this question. Pulmonary function changes in acute bronchial asthma in untreated patients. Decreased total lung capacity, increased FVC, increased residual volume, increased FEV. So, after discussing the pulmonary functions in the obstructive lung diseases, we will come back to this question again. Okay, so if you see the pulmonary function test in obstructive lung diseases. So, the pulmonary function test in patients with the obstructive lung diseases is that FEV₁ by FVC will be reduced. Okay, why is it reduced? Right, we will analyze and come to the scenario why it is reduced. Okay, first of all, what is the first step in the systematic interpretation of your pulmonary function test? Determine the FVC. Right, determine the FVC. FVC, that is forced vital capacity, in OLD it is either normal or slightly decreased. Right, it is either normal or slightly decreased. Now, let me explain why this FVC, it is normal or slightly decreased in case of OLD. So, for that you need to know what is this FVC. FVC is what? Just now we have discussed. It is a determination of the vital capacity from a maximally forced expiratory effort. Now, what does this FVC contain now? Right, what does this FVC contain? It is nothing but your vital capacity, right? So, vital capacity, it contains inspiratory reserve volume, it contains the tidal volume, and it contains the expiratory reserve volume, right? And tidal volume, again it contains the inspiratory component and as well as the expiratory component, right? As well as the expiratory component. Now, inspiratory reserve volume, right? What did we discuss in obstructive lung diseases? There is no problem during inspiration. So, your IRV is normal and your inspiration, this is also normal, right? Because during inspiration there is no obstruction. But expiration or expiratory component of tidal volume is reduced and expiratory reserve volume of your vital capacity is also reduced. So, overall, if you take the vital capacity, it is reduced. Why? Because your expiratory component of tidal volume and expiratory reserve volume is reducing. So, that is the reason why vital capacity is reduced. So, thereby, what will happen to your FVC? It is reduced. Then when it will be normal? For example, if the individual is having the mild state of the disease or earlier state of the obstructive lung disease, then the FVC may be normal. Then you take FEV₁. FEV₁, let me tell you, it is decreased out of proportion to FVC. Right, it is decreased out of proportion of the FVC. Okay, now why is it decreased out of proportion of the FVC, forced vital capacity? So you take FEV₁. In this FEV₁, you have only expiratory component, right? You have only expiratory component. Inspiratory component is not there. And what is that we have discussed in obstructive lung diseases? In obstructive lung diseases, the expiration is reduced. Right? In obstructive lung diseases, the expiration is reduced. Okay? So that is the reason why FEV₁, it is decreased out of proportion of the forced vital capacity. And if you take the ratio FEV₁, we have discussed that it is grossly reduced, and FVC, we have discussed that it is normal or slightly reduced. So numerator is more reduced than compared to that of denominator. So overall, what will happen to your ratio? The ratio will be decreased. Okay. Next, then peak expiratory flow rate, the another important parameter in obstructive lung diseases. In peak expiratory flow rate, what is that you are measuring? The expiration you are measuring. So your peak expiratory flow rate, this is also reduced. What happens to your total lung capacity? Total lung capacity is increased. Now, why do you think that the total lung capacity is increased? Why? Because whatever the air the individual is inhaling, it is not coming out. The expiration is reduced. So whatever the air goes in, it is remain within the lung. So your total lung capacity is increased. So TLC is increased. Then what will happen to your residual volume? Simultaneously, even your residual volume is also increased, because the amount of air which is going in and not coming out is increased. The amount of air which is present within the lung even after forceful exhalation is residual volume. And here the exhalation is reduced because of an obstruction during the expiration. So residual volume increases. And simultaneously, what will happen to your functional residual capacity? That is also increased. Why? Because functional residual capacity, it has a component that is the residual volume. So residual volume is increased, so your functional residual capacity is also increased. Okay. So if you see this question now, pulmonary function changes in acute bronchial asthma in untreated patients. Decreased total lung capacity, increased FVC, increased residual volume, increased forced expiratory volume. So if you see the answer here, first of all, acute bronchial asthma, it is an obstructive lung disease. Right? It is an obstructive lung disease. Okay. So, because your acute bronchial asthma is an obstructive lung disease, in obstructive lung disease, what will happen to your residual volume? It is increased. And what will happen to your total lung capacity? It is decreased. What will happen to your forced vital capacity? That is also decreased. What will happen to your forced expiratory volume at the end of first second? That is also decreased. Okay. So the correct answer here is increased residual volume. That is the correct statement. So we have discussed about the obstructive lung diseases. Now let me take up the discussion of restrictive lung diseases. See, restrictive lung diseases, they are a category of the disorders where the lung parenchyma and as well as the pleura and extrapulmonary tissue is also affected. So basically the word itself tells you that there is restriction of lung expansion. Right? Restriction of the lung expansion. So this restriction of lung expansion is due to, right, is due to pathology in the lung parenchyma, right, is due to pathology in the pleura, is due to pathology in extrapulmonary tissue. Okay, so because of pathology in these areas, either in the lung or in the pleura or in the extrapulmonary tissue, there is restriction of the lung expansion. So now what will happen in the restrictive lung disease? Definitely there is decrease in the lung volume. Right, definitely there is decrease in the lung volume. Okay, so why there is decrease in the lung volume? Because there is restriction of the expansion of the lung. Why? Because of pathology in the lung parenchyma or in the pleura or in the extrapulmonary tissue. What is that? I will tell you. So, and in these individuals, because of decrease in the lung volume, there is increase in the work of breathing. Right, there is increase in the work of breathing and there is inadequate ventilation. Right, there is inadequate ventilation or oxygenation. Okay, so that is what will happen in the restrictive lung disease. And you should know what are the various disorders which comes under restrictive lung diseases. So I said you, the pathology can be either in the parenchyma or in the pleura or in the extrapulmonary tissues. Now first, let me discuss the parenchymal causes for restrictive lung diseases. So the mnemonic is SPEED, but the spelling slightly altered, SPID. S stands for sarcoidosis. P stands for pneumoconiosis. I stands for idiopathic pulmonary fibrosis. D stands for drug induced or radiation induced interstitial lung diseases. Right, drug induced or radiation induced interstitial lung diseases. These are the parenchymal causes for restrictive lung diseases. Then you take extraparenchymal, that is pleural disorders. So pleural disorders which will cause the restrictive lung diseases, that include pleural effusion and then pneumothorax. Even these disorders, they will restrict the lung parenchyma to expand. Then extraparenchymal causes for restrictive lung diseases. So if you take extraparenchymal, the pathology could be either in the neuromuscular junction, that is either in the respiratory muscles or the nerve supplying the respiratory muscles, that will be your neuromuscular diseases causing restrictive lung diseases, or the pathology could be in the chest wall itself. So if you take the neuromuscular diseases, the example is diaphragmatic palsy. Right, the example is diaphragmatic palsy. So diaphragm, it is the muscle of inspiration and it is the main muscle of inspiration. Right, it is the main muscle of the inspiration, and you have to remember that nerve supplying to the diaphragm is the phrenic nerve, and phrenic nerve is having the root value C2, C3 and as well as C4. So if there is high cervical spine injury, right, if there is high cervical spine injury, High cervical spine injury in the sense the pathology is to your C2, C3, C4 spinal nerve. So if there is a high cervical spine injury also, then the root value of your phrenic nerve is damaged. Your phrenic nerve is damaged, and phrenic nerve which is supplying to the diaphragm is damaged, and thereby there can be diaphragmatic palsy. So when there is diaphragmatic palsy or cervical spine injury, the main muscle of inspiration is gone. So expansion of the lung does not occur. There will be restriction of the lung. Next, another important neuromuscular disorders are Guillain-Barré syndrome. See, Guillain-Barré syndrome is an autoimmune disorder, right? And it is an acute inflammatory demyelinating polyneuropathy. The antibodies are formed against the myelin sheath, thereby causing demyelination. And Guillain-Barré syndrome, it is an ascending type of paralysis. Initially, the lower limbs are paralyzed, then trunk muscles are paralyzed, then upper limb muscles are paralyzed, and later on in the late stages, there will be total motor paralysis. Respiratory muscles are paralyzed last. That is what will happen in the Guillain-Barré syndrome. Okay. Then the other important is muscular dystrophies. Right. The other important condition is muscular dystrophy. See, muscular dystrophies, most of these patients with the muscular dystrophies like Duchenne's muscular dystrophy, Becker's muscular dystrophy, right? And we have myotonic dystrophy. These patients with muscular dystrophies, they ultimately die because of respiratory insufficiency. And why is that? Because in the later stages, the respiratory muscles are paralyzed. Okay. So these are the neuromuscular causes for the restrictive lung diseases. Then you take the chest wall disorders. Chest wall disorders include kyphoscoliosis, right, where there is forward bending of the spine and lateral bending of the spine. So forward bending of the spine and lateral bending of the spine will restrict the expansion of the lung, resulting in restrictive lung diseases. Then followed by that, obesity. See, in obesity, there is a thick chest wall because of excessive accumulation of the fat surrounding the rib cage. So this excess fat will not allow the lung to expand, resulting in restrictive lung diseases. Then followed by that, ankylosing spondylitis. So ankylosing spondylitis, if you see, it is a disorder which is associated with HLA-B27, and in these individuals, the bones which are mainly affected is the sacroiliac joint, and another important joint which is affected is the spine. There will be squaring and fusion of the vertebra. So because of the squaring and fusion of the vertebra, you have the bamboo spine. So that bamboo spine will not allow the lung to get expanded. And not only that, in patients with ankylosing spondylitis, there will be fibrosis of the lung parenchyma as well. So these are your extra parenchymal causes for restrictive lung diseases. Now, let me tell you what will be the pulmonary function test in restrictive lung diseases. So, if you see the pulmonary function test in the restrictive lung diseases, first of all, FVC, the first step in the interpretation of the pulmonary function test is the FVC. Forced vital capacity is decreased, right? And how much it is decreased? It is decreased more than obstructive lung diseases. Okay, why? Because in the forced vital capacity, as already we have discussed, what are all the components? Inspiratory reserve volume, tidal volume, expiratory reserve volume. Now everything is reduced here in the restrictive lung diseases, but it was not the same in obstructive lung diseases. So that is the reason why FVC is decreased more than compared to that of the obstructive lung diseases. Then if you see FEV₁, it is decreased in proportion, right? It is decreased in proportion to FVC. right? It is decreased in proportion to forced vital capacity. So your FEV1 and FVC both are reduced, and both of them, they are reduced within the same proportion. So that is the reason why if you take FEV1 by FVC, what will happen to the ratio? The ratio is near normal. Right? The ratio, it is near normal. Why? Because both your numerator and denominator both have been decreased, and both have been decreased in proportion to each other. Or your FEV1 by FVC is increased if suppose FVC is more decreased than compared to that of FEV1, which can happen. Then forced mid-expiratory flow rate. Forced mid-expiratory flow rate, this is also decreased. Right? Forced mid-expiratory flow rate, this is also decreased. And I said you this forced mid-expiratory flow rate is reduced both in OLD and RLD, and it is more sensitive in OLD rather than the RLD. Then what will happen to your total lung capacity? The total lung capacity is also decreased. And what will happen to your residual volume? Residual volume also generally decreases. Right? I am using the word generally. Right? Why am I using the word generally? I will discuss. So residual volume generally decreases, and functional residual capacity is also decreased. Right? So this will be the pulmonary function test in the restrictive lung diseases. Now, if you see a question here, all of the following are true about chronic obstructive pulmonary disease or chronic obstructive lung disease except decreased FEV1, decreased mid-expiratory flow rate, increased residual volume, decreased diffusion capacity. Now, chronic obstructive lung disease, it has two important subtypes. First of all, it is an obstructive lung disease, right? And it has two subtypes. One is your chronic bronchitis, and another important subtype is emphysema. Right? Another important subtype is emphysema. And in between these two, which is more common? Chronic bronchitis, it is more common than compared to that of the emphysema. And in obstructive lung diseases, FEV1, it is decreased. Mid-expiratory flow rate, that is also decreased. Residual volume, it is increased, right? That is a true statement. But if you take the diffusion capacity is decreased is a wrong statement. Let me tell you, diffusion capacity is measured with the help of carbon monoxide. We have discussed that we call it as DLCO, that is diffusion capacity of the lung for carbon monoxide. So it is the capacity of the lung which tells you whether the gases can move from the lung into the blood, from the blood into the lung. That is what is your DLCO. So where should be the site of pathology for the decreased diffusion capacity? The site of pathology should be at the level of the alveoli. And out of these two, emphysema is the disorder, the site of pathology is at the level of the alveoli, whereas in chronic bronchitis, the site of pathology is at the level of the bronchus in the respiratory tree. So in chronic bronchitis, your DLCO will be normal. Right? Your DLCO will be normal in chronic bronchitis. But whereas you take in patients with emphysema, DLCO will be decreased. Right? In patients with emphysema, the DLCO, that is diffusion capacity of the lung for carbon monoxide, will be decreased. So, because in the question it is not mentioned clearly whether it is chronic bronchitis or emphysema. So what is that I have to think now? I have to think of the chronic bronchitis itself. Why? Because chronic bronchitis, it is the most common then compared to that of emphysema in case of the chronic obstructive lung disease. So that is the reason why the incorrect statement is decreased diffusion capacity. Why in chronic bronchitis the DLCO is normal. Now, because we have discussed the differences between OLD and RLD, let me take up the discussion of the OLD and as well as the RLD differences. You take FEV₁, it is decreased in both. FVC is also decreased in both. But the only thing is that FEV₁ by FVC, it is decreased in obstructive lung diseases, whereas in restrictive lung diseases, it is either normal or increased. What is the reason we have discussed? Why? Because in obstructive lung diseases, why is the ratio decreased? Because your numerator is more decreased than compared to that of the denominator. That is the reason why your obstructive lung diseases, FE₁ by FVC is reduced overall, because numerator is more decreased than compared to that of denominator. Whereas in restrictive lung diseases, both of them, FEV₁ and FVC, both of them have been decreased in equal proportion. So that is the reason why your FEV₁ by FVC will be normal or it can be increased. Then forced mid-expiratory flow rate. Forced mid-expiratory flow rate, this is also reduced in obstructive lung diseases and as well as the restrictive lung diseases. But it is more sensitive, right? It is more sensitive in obstructive lung diseases than the restrictive lung diseases. Then coming to your total lung capacity. Total lung capacity in obstructive lung diseases, it will be increased, whereas in restrictive lung diseases, the total lung capacity will be decreased. Diffusion capacity of the lung for carbon monoxide, it will be normal in patients with obstructive lung diseases except in patients with the emphysema. In patients with emphysema, DLCO will be decreased. Right, DLCO will be decreased. Whereas in restrictive lung diseases, what will happen to your DLCO? See, in restrictive lung diseases, again we have parenchymal type of restrictive lung diseases, and then we have extra parenchymal causes for restrictive lung diseases. Parenchymal causes, the DLCO will be reduced, and extra parenchymal, the DLCO will be normal. Right, the DLCO will be normal, where in extra parenchymal. Okay, so these are the differences between the obstructive and as well as restrictive lung diseases of the various parameters of the pulmonary function test. Now let me discuss in detail about the DLCO. So DLCO, if you see in restrictive lung diseases, right, just now we have discussed that if you see in parenchymal causes for restrictive lung diseases, the DLCO is decreased, whereas in extra parenchymal, right, whereas in extra parenchymal, the DLCO, it remains normal. Right, it remains normal. Okay, next. So in a patient with a restrictive lung disease, the presence of a normal DLCO will exclude the intrinsic lung diseases. Right, will exclude the intrinsic lung diseases. Okay, then you take DLCO in obstructive lung diseases. So DLCO in obstructive lung diseases only in patients with emphysema. This is reduced. Whereas in other causes of the obstructive lung diseases, the DLCO, it remains normal. Right, DLCO, it remains normal. Okay, so this is a very important parameter to differentiate what is the underlying lung disease. Then you take the residual volume also. Residual volume in case of obstructive lung disease, no doubt in that it is increased, right? Whereas in restrictive lung diseases, what did I tell you? I have used the terminology generally decreases. So you have to remember that mainly in case of intrinsic or parenchymal type of restrictive lung diseases, the residual volume is decreased. Whereas in extraparenchymal, right, in extraparenchymal type of restrictive lung diseases, the residual volume, it remains normal, right? Residual volume, it remains normal, okay? Or it might be increased. Why? Because in extraparenchymal type of restrictive lung diseases, like you take kyphoscoliosis, or you take obesity, or you take phrenic nerve injury, or cervical spine injury, muscular dystrophy, Guillain-Barré syndrome, in all these, the lung parenchyma is normal. Lung parenchyma is not affected. It is only restriction of the expansion of the lung what is happening in case of the restrictive lung disease. So that is the reason why, because the lung parenchyma is absolutely normal in patients with extraparenchymal cause of restrictive lung diseases, residual volume also remains normal, right? Residual volume also remains normal, okay? So going back to the question, all of the following are true about chronic obstructive lung disease except the answer is decreased diffusion capacity. That is what we have discussed now, right? Next, you see another important question. Features of the restrictive lung disease. FEV1 by FVC decreases and compliance decreases. FEV1 by FVC increases and compliance increases. FEV1 by FVC decreases and compliance increases. FEV1 by FVC increases and compliance decreases. So, in restrictive lung diseases, FEV1 by FVC increases. So, you have two options like that, B and as well as D, where your FEV1 by FVC is increased. But if you take the compliance, compliance is decreased. Compliance means what? Distensibility. Right? Compliance is nothing but distensibility. That is, expansion of the lung is reduced in case of the restrictive lung disease. Okay. Now, you see another question. So, if you see this question, the abnormal preoperative pulmonary function test in a patient with severe kyphoscoliosis includes normal residual volume and reduced total lung capacity, reduced FEV1 by FVC, reduced mid-expiratory flow rate, increased functional residual capacity. So, kyphoscoliosis, it is a type of restrictive lung disease. And what type of restrictive lung disease is this? It is an extraparenchymal type of restrictive lung disease. So, just now we have discussed that in patients with extraparenchymal type of restrictive lung diseases, the residual volume, it remains normal, right? It remains normal. But what will happen to your total lung capacity? The total lung capacity in patients with kyphoscoliosis, it will be reduced. So, the answer to this question is normal residual volume and reduced total lung capacity. Whereas FEV1 by FVC in case of restrictive lung diseases, it will be normal or increased. And forced mid-expiratory flow rate, it is reduced in restrictive lung diseases, but this is more sensitive in case of OLD rather than the RLD. And functional residual capacity in patients with the restrictive lung diseases, it will be reduced. So, what is the correct answer? The correct answer is the first option. Okay. Next, the other question is, a patient presents with decreased vital capacity and total lung volume or total lung capacity. What is the most probable diagnosis? So, there is decrease in the vital capacity and as well as decrease in the total lung volume. So, what should that be? It should be a restrictive lung disease, because total lung capacity in obstructive lung diseases, it increases. So, among these, which is the restrictive lung disease? That is your sarcoidosis. Bronchiectasis, cystic fibrosis and asthma, all of them are the obstructive lung diseases, but sarcoidosis, it is a restrictive lung disease. Okay. Now, so this is the summary of how you have to interpret the pulmonary function test. So, first step, you need to interpret the FVC. Second step, you need to interpret the FEV1. If both are normal, then you need to consider it as the normal pulmonary function test. For suppose, if both are reduced, then you need to consider there is presence of the disease. In such case, you need to take FEV1 percentage. What is FEV1 percentage? That is measurement of FEV₁ by FVC. That is what is called FEV₁ percentage. And in the FEV₁ percentage, for suppose if it is normal or increased, then it will be restrictive lung disease. And your FEV₁ percentage, if it is reduced, then it will be your obstructive lung disease. Right? Then it will be your obstructive lung disease. So this is about the interpretation of pulmonary function test. Now you need to know the flow volume loops, because there are many questions on the flow volume loops of your pulmonary function test. This is the normal flow volume loop. Right? This is the normal flow volume loop. Now what does this normal flow volume loop contain? You have the inspiratory component and you also have the expiratory component as well. So on the negative axis, right, on the lower side you have inspiration. And how to remember that? It is very simple. See, whenever we inhale the air moves down. So on the lower aspect of your flow volume loop is your inspiration, and whenever we exhale, the air moves out. Okay, so upper component will be your expiration, right? Lower component will be inspiration and the upper component will be expiration. Now this is a normal flow volume loop. Now you see questions on this. The question is, the pattern shown on the flow volume loop is obstructive lung disease, restrictive lung disease, normal curve, mixed pattern. So if you observe this here, this is the inspiratory component and this is the expiratory component. Actually, how it should be? It should be like this. Okay, so this is how the expiration should be. But what has happened to the expiration? The expiration is reduced. So when the expiration is reduced, what does that suggestive of? That is suggestive of an obstructive lung disease. So the pattern which is shown on the flow volume loop, it is an obstructive lung disease, right? It is an obstructive lung disease. Now I'll show you one more question. The flow volume curve shows the presence of COPD, interstitial lung disease, variable extrathoracic obstruction, variable intrathoracic obstruction. So if you observe that very closely, this will be your inspiratory component which is reduced, right? Inspiratory component is reduced, whereas the expiratory component, if you see, it is absolutely normal. Right? It is absolutely normal. Which one? The expiratory component. So now where is that you will have the following flow volume loop? You take in patients with chronic obstructive pulmonary disease. It is mainly the expiratory component that will be reduced. So you will have these type of flow volume loop in case of variable extrathoracic obstruction. Now, what is the example of the variable extrathoracic obstruction? That is the presence of retrosternal goiter. Right, that is the presence of the retrosternal goiter. So what is this retrosternal goiter? Goiter is nothing but it is a swelling of your thyroid gland. Right, it is a swelling of your thyroid gland. So when the thyroid gland which is being swollen and which is present retrosternally, during inspiration, right, during inspiration, what will happen? As the respiratory tract, that is when as the trachea is moving down, even the goiter which is attached to the trachea, that also moves down. So now what the goiter will do? Goiter will compress the trachea because it is moving down behind the sternum. So sternum will compress the goiter, goiter will compress the trachea. So thereby what will happen to your inspiration? Inspiration will be reduced. But during expiration, the trachea moves up. When the trachea moves up, even the goiter also moves up, the obstruction will be reduced. So thereby the expiration will be normal. So in variable extrathoracic obstruction, you will have these particular pattern. Okay, whereas you take an interstitial lung disease. Interstitial lung disease is a restrictive type of lung disease. Both your inspiration and expiration both are reduced in case of the interstitial lung disease. Okay, so the answer in this question is the variable extrathoracic obstruction. Example is the retrosternal goiter. Okay. Next, now if you see this flow volume loop, see in this flow volume loop, what is that you are observing? In this flow volume loop, you can observe that only expiratory component is reduced, but whereas the inspiratory component is normal. right? The inspiratory component is normal here. The expiration is reduced. Okay. So that is, expiration is flat. What is that suggestive of? That is suggestive of variable intrathoracic obstruction, and example, laryngeal tumor. See, what will happen in the laryngeal tumor is that, right? So it is a pedunculated tumor. Consider this is a tumor. So when the individual is inhaling the pedunculated tumor, right? So it moves down. Right? It moves down. So as the air moves in, right? The air moves in, the pedunculated tumor, it moves towards the wall. So that is the reason why the air can comfortably pass down. But when the individual is exhaling, right? But when the individual is exhaling, what will happen? The air will hit the peduncle. So again, the tumor will reach to the native position. So thereby, what will happen to the expiration? The expiration will be reduced. So that is the reason why, if you can observe, the expiratory component is reduced in this flow volume loop. So only expiration being reduced but the inspiration being maintained normal, you can expect either an obstructive lung disease, or when the expiratory pattern is completely flat, you can expect a variable intrathoracic pattern. That is, example is your laryngeal tumor. Okay. Now, you see another important flow volume loop. So if you observe this flow volume loop, both your inspiration is reduced and expiration is also reduced. Now, where will you have this? So you will have this in patients, that means both are reduced. You will have this in patients with a restrictive lung disease, right? Or you can have within the disorder associated with the respiratory tree, like example, tracheal stenosis, right? Example, tracheal stenosis. So in tracheal stenosis, so in which group of individuals you can have this tracheal stenosis? You can have this tracheal stenosis secondary to prolonged intubation. There you will have this tracheal stenosis. So in patients with tracheal stenosis, both inspiration and expiration, both are reduced. Okay, both inspiration and expiration becomes flat. So what is the example? That is tracheal stenosis, right? So this is the normal flow volume loop. This is the flow volume loop where you will have in patients with the obstructive lung diseases. You will have this in patients with fixed airway stenosis or fixed airway obstruction. Right. I'll just give you one clinical scenario. A 65-year-old man is evaluated for the progressive dyspnea on exertion that has occurred over the course of the past 3 months. Right, evaluated for progressive dyspnea on exertion. His medical history is significant for an episode of necrotizing pancreatitis that resulted in multi-organ failure and acute respiratory distress syndrome. He required mechanical ventilation for 6 weeks prior to his recovery. He also has a history of 30-pack year of tobacco, quitting 15 years previously. He is not known to have the chronic obstructive pulmonary disease. On physical examination, low-pitched inspiratory and expiratory wheeze is heard, loudest over the mid-chest area. On pulmonary function testing, the forced expiratory volume FEV₁ is 2.5 liters, that is 78% of the predicted value, and FVC is 4 liters, that is 94% of predicted value, and FEV₁ by FVC is 62.5%. That means what? It is reduced. The flow volume curve is shown in the figure. What is the most likely cause of the patient's symptom? Aspirated foreign body, chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis, subglottic stenosis, unique lateral vocal cord palsy. So what is that you are observing here? Your inspiratory component is reduced and expiratory component is also reduced. Both are completely flat. And what is a very important history? The very important history is required mechanical ventilation for almost 6 weeks prior to his recovery. That means a prolonged intubation that might have made the individual to develop fixed obstruction. And what is that particular fixed obstruction? That is nothing but your stenosis of the respiratory tree. Right? That is nothing but the stenosis of the respiratory tree. That is subglottic stenosis. Right? The answer is subglottic stenosis. So the patient is presenting with subacute dyspnea. Stridor, right? Where the individual is having noise during both inspiration and expiration. And there is also airflow obstruction. And this is consistent with the diagnosis of subglottic stenosis. Okay, and this is related to a prior prolonged mechanical ventilation. And how can you confirm this? This is confirmed by finding of fixed airflow obstruction on the flow volume loop, right? And this flow volume loop, it is derived from spirometry. So the answer is the subglottic stenosis. So the purpose of your pulmonary function test is mainly to differentiate OLD and RLD, to differentiate the intrathoracic and extrathoracic obstruction, and to make out if there is any presence of the fixed stenosis. So with this, I wind up this very important session, that is pulmonary function test. Thank you very much.